Good evening, everybody. Today I'm coming up with a topic which is very commonly known to all of you, knee osteoarthritis or knee arthritis, and its end result, total knee replacement. Just trying to bring some basic facts to you. Now, when we're talking about knee arthritis, what is knee arthritis? If you look at this model where the muscles have been stripped out, if you look at the joint, this is the joint. Now, when you're talking about the knee joint, this is the femoral bone, this is the tibial bone, and you have the patella, that's the kneecap. If you look from the side, this is also part of the knee joint, that is the patellofemoral joint. So you have the patellofemoral joint, you have the tibiofemoral joint or femorotibial joint. So we have the inner part, this is the inner part, which is called the medial joint, this is the lateral joint, and this is the patellofemoral joint. So when the arthritis is occurring, for whatever arthritis it may be rheumatoid arthritis, the commonest form, it is osteoarthritis, whatever arthritis, the basic thing that happens is wearing down of this blue thing, that is the articular cartilage. Now when we talk about knee especially, it is not only the articular cartilage, there is also wearing down of this pink structure which you can see, which is called the meniscus. Hope you are able to see this. So this is wearing down of the blue thing, that's the articular cartilage, as well as wearing down of the pink thing, that is the meniscus. Along with, later on you have the wearing down of the ligaments, you have wearing down of the bones, which happens later on. So a person who's suffering from arthritis, once her or his articular cartilage meniscus is completely worn out, completely deranged, completely debrided, it is expected that patient will be having a lot of pain. 1, 2, the patient may have instability. When the arthritic process, it spreads on to the ligaments, these ligaments are no more strong. As a result, the patient starts wobbling once he or she walks. So that is called instability. So the patient will have pain, the patient will have swelling around the knee, the patient will be unstable while walking. So walking for the patient is an absolute nightmare. So medically we say that the activities of daily living, ADL, is terribly absolutely not up to the mark. The patient is suffering, and that is the time when we orthopedic surgeons advise the patient to go in for total knee replacement surgery. Now, this total knee replacement surgery is not a rocket science. It's a simple thing that you have to understand, that when a doctor advises total knee replacement, some people fall from the sky. Oh my God, total knee replacement, how complicated it will be. No, it is not complicated. It is something to make your life easy. It is something to make your life painless. It is something with which you can walk properly. You can go back to your younger days, your better days. So what is done in total knee replacement? Now here I'm holding you a model of a total knee replaced implants. So what we do, what we surgeons do, we, while operating, we take the patella on one side, that is the kneecap, we open up this joint and we carve the femur, the lower end of the femur, we carve the upper end of the tibia. There are 5 curves, that means 5 lines or 5 cuts across the lower end of the femur. The front cut, the lower cut, the back cut, the chamfer cut, front chamfer cut, the back chamfer cut. So 5 cuts, and over these 5 cuts, or carving out nicely of the femur, we put in this processes. This is the femoral processes. And over the tibia, we take a transverse cut, a front to back cut, and over this you have the tibial processes, the shiny golden one. And in between comes the polyethylene, the medical grade polyethylene, which replaces the articular cartilage once upon a time which you used to have. And basically, knee replacement is not all about cuts, it's about balancing these ligaments. So the success of knee replacement are the proper cuts, a good processes, and balancing the ligaments. Now these things, these metals are of different types. depending on what you can afford. You can have oxynium, you can have cobalt chromium, you can have titanium, you can have zirconium, and this is polyethylene. The types of knee replacements are also different according to the amount of advancement of the knee arthritis. The standard one that we are using mostly is the non-constrained knee. Out of that, two types are basically there. One is where we are replacing, this is called the posterior cruciate ligament. In one type, we replace the posterior cruciate ligament, we remove it, and we use something like this, which is called a posterior cruciate sacrificing ligament, ligamentous total knee prosthesis. And the other type, where we retain the posterior cruciate ligament and we go for posterior cruciate retaining knee replacement device. So when the patient comes to us, it is not only the X-ray. Now look at this X-ray. See how deranged the bones are. I mean, not deranged, I mean how deranged the knee is. The space between the two bones is gone, both the knees. This is osteoarthritis typically. That's because the cartilage which was there in between the joint is totally gone. So we do not take our decision on the X-ray. We take the decision on the amount of trouble the patient is having. We are not going to do an operation just because the knee looks bad on an X-ray. We are going to do the operation only when the patient is suffering a lot, and we understand that, the patient understands that. We sit across the table, discuss it, and then accordingly proceed.